the clinical anatomy and related to the spinal endoscopy. Yes, we are not going to discuss many other interventions, but mainly this is all around the spinal endoscopy. So this is what we have with us whenever we plan for the spine endoscopy. So we had to uh, be thorough in our understanding of the anatomy, correlating with the MRI, because we will be crossing some, we are breaching some muscles, some ligaments. We are entering into the bone, into some foramen, entering into the canal. There are nerves, there are vessels, there are fascia, there are ligaments. There are so many structures which are there before we reach our disc, that is our target fragment. So we must understand this anatomy very well. Please keep yourself moved, Zaya Mushakar. Yeah. People are still joining. So these are the muscles which will be which are surrounding your spine wherever you are working. Over here we have some muscle groups. We must know all these muscle groups. On the posterior abdominal wall we have this psoas major muscle, then we have this quadratus lumborum muscle over here, which we can see on MRIs also. And this is the group of the paraspinal muscles, which are interspinalis muscle, which is a very thin muscle over here. And then we have this multifidus muscle followed by longus colli muscle over here, and the iliocostralis. So these are the group of the paraspinal muscles which we encounter when we do spinal endoscopy, and we have to cross one of these muscles when to reach the foramen or the disc space. So for that, we must understand the coronal sections of the MRI, and we must know how it looks on MRI. What are the depths of these? What are the bulk? What the bulkiness of these muscles? So it all depends on the patient habitus also. So before taking the patient inside OT, when we take the MRI, that will give us some clue about the bulkiness of these muscles and how safe it is to go inside, and what angulation and what distance we can go safely. So all these things we can see if we know the anatomy very well. So you can see this is when we see on the axial sections, we can see all these muscles. When we see the coronal sections, that time also we can see all these muscles, and we can make out that how safe it is to go at what angulation. So majority will be focusing the anatomy part towards the safety part, because what all structures we are going to encounter, and how to safely avoid those important structures, and we can do our endoscopy safely. So you can see this is the axial section where we can see the all the muscles over here. This is the iliocostal muscle from where we should go in. Normally we breach this muscle and to reach the foramen. So that's the coronal section. Coronal section, we know that MRI, when we see we have the sagittal sections, we have the axial sections, and we have the coronal sections. So coronal sections, we know that this is basically to find out when we want to trace something, like if we want to trace the nerve roots, if we want to trace something which is like vertically oblique, in those cases like SI joint, when we want to trace them, that time we go for this coronal sections. So I think you all must know that whenever we order the SI joint MRI, that time we just write down the MRI, the SI joint, and they usually go for the coronal sections because we want to see from the anterior to posterior the entire joint. So similarly, we can see in the coronal sections, we can see all these muscle groups. You can see all this is interspinous muscles, multifidus muscles, and you can see the fascia in between there, over there. This these muscles group as we go anteriorly, because if you see here, this may not be same everywhere at all the level, because as we go anteriorly, because of this lordosis, the muscle is already gone from here, but we still have some muscle over here, and you can see here we almost reached the spinal canal at this level. You can see this blue line which is going from backward to the forward. So you can see all these muscles and fascias, and you can see the spinous muscles over there, and this is how we can trace all these muscles. Now, this is now you can see our lamina over here, the facets over here, and you can enter the spinal canal, and you can see all the nerve roots here. So I'll show you that coronal section, how to see the coronal section, and how to detect these um, um, pathologies in the coronal section also. So this is how we can trace these traversing and exiting routes. We can see them. We can see their relation with the herniation part of the disc, and whether it is compressing the nerve, pushing the nerve medially, laterally. All these things we can see on the coronal sections. So coronal sections are also really very important for us. We must know how to read them. And also in the axial section, we can see all these muscles. You can see here, this is a bulky muscle over here. And as we go down towards the L3, L4, L4, L5, you can see there's a good bulk over here. Bulkiness of the muscles are there. So as you see from here, we have the thin muscles over here, and we have this kidney over here, the peritoneum over here, retroperitoneal space over here. So all these things we can see on the axial images. This will give us some idea about the safety and how much deep we can go, how far lateral we can go. So you must know all these sections. There's a fascia which is called the thoracolumbar fascia. We all have read about this thoracolumbar fascia. What is the significance of this fascia for us is that, as we know that there are three layers of the thoracolumbar fascia. There's anterior, middle, and the posterior layer. So all these layers of the thoracolumbar fascia, they are highly innervated. That means when we go inside, and the local anesthesia, most of the time we do these intervention, these procedures, endoscopic procedures under local anesthesia. At times, some people they prefer MAC with sedation. Some people they do also do it under general anesthesia. But most of the pain physicians we have seen that they do under local anesthesia. So we must know where to inject these local anesthetics so that we don't have pain during the procedure and the patient is also comfortable. Why it is important to understand this? Because if we don't anesthetize these areas, these thoracolumbar fascias, uh, patient may feel pain during the procedure. If you are doing it purely under local anesthesia, patient may feel pain, and that will cause sudden contraction of the muscles, and that will basically disturb you also, to the patient also. There's a lot of discomfort to the patient also, and that will also hamper your performance because the muscles are contracting and you're not able to concentrate on the procedure, and you're having a lot of contractions happening in the muscles, and your working channel is moving. So that is why it is important. So whenever we go under fluoroscopy guidance, when we go towards the annulus, this is what I normally do. I go with this 20 gauge needle, long needle, 15 centimeter needle. I go up to the annulus first, into the trajectory, whatever we have selected. I go up to the annulus. I inject some just 0.1, 0.2, 2.5 ml of local anesthetic into the annulus. And whenever we encounter these fascia, so how you know that we are encountered in fascia, that you get a loss of resistance over there. So whenever you are getting this pricking sensation over there, you just inject local anesthetic over there. So while going inside, if you encounter these fascia, patient will have a little bit of pain. You inject local anesthetic over there. Go inside. Whenever again the patient will have some pain, give some local anesthetic over there, and go up to the annulus and then inject over there. Normally, what I also do is that this also you can apply in your practice also. Whenever I go over the facet, when we hit the superior passage, that time also just give 0.1, 0.5 ml of the local anesthetic over there also. Because once you go into the foramen, we are moving our working channel. This facet will also cause pain. The movement of the facet joint, that also causes pain. So just give local anesthesia over the facet joint. That will give some relief to the patient. So it will be easy for you to manipulate. So this thoracolumbar fascia, you must anesthetize it very well. It is very highly innervated with the nerve fibers. So once you do that, then it will be very easy. You can do entire procedure, and the patient will not even come to know, okay, what is happening. Retroperitoneal space is one of the space which we must avoid. We must know about this space, where it lies, and which we can see on MRI, we can see on CT scan, but obviously we cannot see it under fluoroscopy guidance till the time we reaches our our target area. We can say it is almost a blind procedure, because we are doing under fluoroscopy guidance only. We cannot see this how deep we are going when we go in the AP views. So most of the complications or the entrance into the intervertebral space happens when we go in the AP view. So if we don't know the depth, the area of this intervertebral space, if you go too deep inside, then we may enter into intervertebral space. So we must know about this retroperitoneal space, as we know that there's a this space just behind the peritoneum over here. We have this retroperitoneal space, and the kidney divides this into anterior pararenal space and the posterior pararenal space. And just behind this retroperitoneal space, we have this soft major muscles and the quadratus lumborum muscle over here. So this is at the level of L1, L2, L2, L3, up to L3, up to upper part of the L4 also. But L4, L5, we do not have these kidneys over there. So there is no division of this anterior pararenal space and the posterior pararenal space. We do have some, uh, you can see here on the CT scan, you can see this retroperitoneal space over here. This is at the L1 L2 level, so that is why it is difficult to go in at the L1 L2 level far lateral. So this also gives you some clue about how lateral we can go and we can avoid this retroperitoneal space. As we go down over here, L3, L4, L4, L5, we have a bulky of the muscle bulk is there. We can safely go far lateral approach in this at this level. One thing is that whenever these MRIs or the CT scan they are taken, so one point of safety is that whenever it is taken in supine position. But when we do these endoscopic procedures, that is in the prone position. So that point of safety is also there. So we have some margin, safety margin is still there with us, because this is taken in the prone supine position, and we are doing in the supine position. So you may get some more additional space when the patient is lying prone, provided your abdomen is free. If the abdomen is not free, that will push the entire gut posteriorly, and it may push this space posteriorly, and you may land up into the retroperitoneal space. So that is, you must understand that we must keep the abdomen free when the patient is in the prone position. If you have any queries in between, you can stop me all anytime. Okay.
Sir, one question, sir. Pankaj, sir.
Yes,
sir, we are keeping abdomen free by putting two pillows like we do in PCNL or like that, or what would be the position of the?
Yes. So I think Shirish.
Yes, sir.
Yeah, I can make out from your voice. So Shirish, basically, as we know that we have to reduce the lordosis also, because there's a lordosis in the lumbar region. We want to reduce that lordosis also. So putting two bolsters under the uh, uh, basically we want to reduce the lordosis also. So there's something called Wilson frame which is available. Wilson frame, right? In that it is like this kind of frame. Okay, where we can reduce the lordosis, we can make a patient in this, patient can lie prone in this position. With this, we can reduce the lordosis, and the center part is free. So the abdomen is free. At the same time, we are reducing the lordosis. We are flexing the spine at the lumbar region. Because as you know, as you flex the spine, the foramen space opens up. So we want that also, right? Understood? If you put up bolsters under chest, under the pelvis, that will increase the lordosis and that will reduce your foramen space.
Mm-hmm. Okay, sir. Got it, sir.
So better to go for this. If you have just availability of the Wilson frame is there. So Wilson frame is available in the market, and these are radio opaque, radio lucents are also there with the plastics inside. So we can use it during spine endoscopy. Okay, understood?
Yes, sir. Thank you, sir.
So avoid and putting any pillow. Some people they do it like for most of the interventional procedures. What we do is we put a pillow under the abdomen and we make a flexion position to open up the space, right? For other procedures, it's okay, we can do that. But for the endoscopy, we should not do that, because that will not just push your abdominal organs posteriorly and push your retroperitoneal space also, but also it will increase the intra-abdominal pressure, will increase the intravenous pressure also, and the patient will keep on bleeding. So that is another reason why we should keep the abdomen free. So this is at the L4, L5 that what